And thank you to Al Stone for inviting me to talk about our work on the development of a breath biopsy test for the detection of lung cancer. And I'm going to talk to you about both the LuCID and Evolution studies this afternoon. So I'm a clinical academic in the University of Cambridge, and my clinical work is undertaken at Royal Papworth Hospital. And in fact, we were reflecting yesterday that it's, I think, about 10 years since I first met Billy, and we first had the ideas to look at lung cancer in a trial, what turned out to be the LuCID trial. So it's been quite a long journey, but great fun. So I'd like to start, first of all, by actually doing the acknowledgements, and firstly to the patients and their families. We, as you'll see, recruited nearly over 1,800 patients to the study, and we certainly couldn't have done it without them. Similarly, although I've listed the principal investigators for the various sites for LuCID here, there were innumerable research nurses at all the 26 sites who actually recruited all the patients. Also, to members of the Al Stone medical team, both past and present, it's been, as I say, great fun working with you, and my funders, Royal Papworth Hospital, Cancer Research UK, and the NIHR SBI programme that gave the initial funding to Al Stone to develop the receiver device. So why lung cancer and why early detection? Well, this year in the UK, lung cancer, unfortunately, will kill about 35,000 people. And although it's the second most common cause of cancer, it is actually the leading cause of cancer death, both in the UK, North America, Europe, and in fact, globally. Now, why is this? Well, the issue really is that, unfortunately, the majority of people with lung cancer present with advanced stage disease, stage 3 or 4. And their survival outcomes are much poorer at that stage. In fact, if you present with early stage disease, stage 1 and 2, and at the moment only about 20 to 25% of people present with early stage disease, your chance of survival is much, much better, of the order of 75, 80%. And therefore, you can see that if we can improve the early diagnosis of lung cancer at early stage, we will dramatically improve outcomes and reduce the number of people dying of the disease. So you may think about screening for lung cancer. And indeed, this has been moving rapidly over the last few years. These are the results of 2 large randomized controlled trials looking at screening for lung cancer. On the left, the American NLST study, and on the right, the recently published Nelson study from Europe. And both studies have shown between a 20 and 26% reduction in mortality from lung cancer in the arm which underwent low-dose CT screening. Incontrovertible evidence that lung cancer screening with low-dose CT in a high-risk population works. And in fact, the UK National Screening Committee in September 2022 recommended to the UK government screening for this condition. And I'm pleased to say that a few months ago, the government did indeed endorse this, and NHS England are now expanding their targeted lung health check programme, so that in the next few years, we should have full coverage in England of all ever smokers between the age of 55 and 74. So what about the rationale for a breath test in lung cancer? Well, as we all know, as you sit there breathing in and out, the breath at which we exhale is in effect a breath print of our phenotype and genotype, our microbiome, how much exercise we take, our diet, whether we smoke or not, and so forth. And it stands, to reason that, as in many areas currently, if we can develop a breath test for lung cancer, we could actually potentially support and enrich the people to be screened. And I'll go into that in a bit more detail in a moment. But you then have to think, well, why isn't there a breath test for lung cancer if it's, relatively straightforward to do this? And if you look at the literature, and we reviewed this a few years ago, there's actually very little agreement in identified biomarkers within lung cancer on the breath. And as I said, there is no routinely used breath test for lung cancer currently. And you think, well, why? What are the challenges here? And when you look at all the work that's been done, the studies vary in design and size. Some are pilot studies, some have small test sets. The sampling has been undertaken in a variety of different ways and to different protocols, which aren't always repeatable. And again, analysis is being done with a variety of approaches from ENOS through to GCMS. So we feel that without solving some of these challenges and doing things in a very robust and reproducible way, it's unlikely that you'll actually be able to develop biomarkers, discover appropriate biomarkers and critically validate them in this setting. So if I had a lung cancer biomarker, in this case, we're talking about a breath biomarker, what would it offer me in different clinical settings? So there are some CT scans on here. On the right-hand side, you can see a large mass in the right lung, which is a patient who had symptoms. They've been losing weight, they had a cough, they were coughing up a bit of blood, getting chest infections. And on one hand, could we develop a simple breath test to differentiate lung cancer like that from benign disease? So that you wouldn't necessarily have to put people through a biopsy procedure, either looking down into their lungs or doing a CT-guided needle biopsy. The other two scans with the yellow arrows show early stage lesions. And in this setting, the question is, could a biomarker, a breath biomarker, help identify early stage cancer? So these are the size of cancers that we see in the screening programs. The majority of patients identified with lung cancer in the screening programs have stage 1 and sometimes stage 2 small lung cancers. And at the moment, we enrich the population to screen using multivariable risk prediction models, epidemiological models, such as the Liverpool Lung Project model or the USPSTF model. If we had a biomarker that was easy to apply, then the question is, could we improve on the cost effectiveness of lung cancer screening? And also, could we improve on participation rates? If someone could undertake a breath test, for instance, in the privacy of their own home, as are done, providing fecal samples in the bowel cancer screening program at the moment. So we set about to develop a study, which we called LuCID, to identify breath biomarkers for detection, and in particular, early detection of lung cancer. And we wanted to evaluate its diagnostic performance in appropriate real-life clinical population, the populations that I see in my clinic and as I've outlined to you already. And our approach to this was to undertake a multi-center case control study of patients coming in under investigation for suspected lung cancer pre-diagnosis. And as you'll see during the study, we also iteratively evaluated the performance of our equipment and optimized the methodology. And you'll also see that we looked at the performance relative to and in addition to the epidemiological risk model, the Liverpool Lung Project version 2. And we evaluated our biomarkers against the published biomarkers in the literature and in the libraries from the work that has gone before. So the study population, as I've mentioned on the left, the inclusion criteria, I'm not going to go through all these in detail, but essentially they were patients being investigated for suspicion of lung cancer, either because they are being referred to chest physicians from their general practitioners with suspicious symptoms, or findings were incidentally found on a CT scan when having other tests. For instance, someone with abdominal pain having a CT of their abdomen and their chest incidentally found a small nodule in the lung. And to support the study, we developed a tool chain, and that ran from the clinic, where we collected samples in the clinic and in the wards using the receiver device and the Casper system. And those samples, the sorbent tubes, were then transported to Alstone, where they were analysed by GCMS. And the results then went to the bioinformatics team and the chemists for the deconvolution and identification of all the peaks on the mass spec. And from there, as I'll show you, we developed our analyses. So again, here you can see on the right-hand side the final equipment we used with the receiver device and the clean air supply and so on. And that was on a little trolley which we could take into clinical areas, which the research nurses pushed around the wards, collecting samples from patients. And we were able to capture not just whole body samples over a short period of time, but actually collecting breath for about 10 minutes or so at a time allowed us to collect low-level VOCs as well. So although I'm not a chemist and there are others on this call who can give you a lot more information about the detail and the methodology, essentially we started with a sampling approach called method 1, and then imaginatively upgraded that to method 2. But essentially method 1 was an early version of the sampling hardware, and there was a wide range analysis method in order to capture as many VOCs as possible. And then as we went on, new sampling improved hardware with lower background VOCs was developed that allowed more sample to be collected, more breath to be collected. And although it was a wide range method, it also allowed capture of smaller VOCs, which in method 1 may have been lost in the noise. And you'll see that in the results section. So this is a somewhat dry slide about the statistical analysis plan, but important at this point I explain what we plan to do, and this was devised before the study data was analysed. We undertook a univariate analysis to look at differences between the cases and controls for individual biomarkers, which was then corrected for gender, body mass, age, and smoking status. And also there was very robust biological validation of the various features we were seeing through structural elucidation from libraries and from the chemists drilling down on the VOCs very precisely. And a lot of time and effort was put into that. In the multivariate analysis, we looked at the diagnostic potential of a combination of biomarkers, and we split our sets, as you'll see in a moment, between training and validation sets. We selected the candidate biomarkers on the training set. Again, they were corrected, as shown there, and then evaluated in a prospective validation set. And from there, we generated ROC curves, which I'll show you later on. And as I mentioned earlier, compared our findings to the Liverpool Lung Project epidemiological risk scores, which was collected on each patient at the time that they were recruited to the study. So we recruited patients at 26 sites across the UK and Europe, as shown there. And this is the consort diagram showing the flow of patients through the study. So we actually recruited 1,844 subjects. Some were excluded either because they had indeterminate clinical diagnosis. So sometimes you get patients with small nodules that you're suspicious are for lung cancer, but they have to be followed for several years to determine whether they are actually a lung cancer or not. And I'm talking about little nodules down at sort of 5, 6, 7 millimeters in size. So we excluded one where we didn't have a definitive clinical diagnosis. And then some were excluded due to technical curation issues. And that left us with 814 controls and 574 cases. Now, I would at this point just like to tell you a little bit more about the controls, because I think it's important you understand what the controls are. Patients were being referred to us for investigation for lung cancer, but not everyone who is referred turns out to have lung cancer. So you might have a cough, and have be coughing up unpleasant sputum and feel unwell and have lost some weight, and you've had an abnormal chest X-ray and a CT scan, and it is suspicious for lung cancer, but actually during investigation it turns out that this is an infective or inflammatory cause and there is no cancer found. And these essentially were the patients who formed the control group. So they were not healthy volunteers, they were patients, symptomatic patients, suspicious for lung cancer who turned out not to have lung cancer. The controls were then followed up for 2 years to ensure that they didn't develop malignancy during follow-up, and some did, so they were excluded because they had occult malignancy, maybe in the bowel or the kidney or somewhere else. So we wanted controls that were in effect clean and had no other cancer. And we ended up with 677 in the primary analysis. And again, the cancers cases, the lung cancer cases, were followed up to ensure they didn't develop any other cancer apart from the lung cancer, and some did. So we ended up with 518. So those, the two groups in blue, are the 2 cohorts that we used, and they were split between the training set 75% and the validation set. And as you can see, they were then also the cancer cases were split between early stage, stage 1 and 2, and advanced stage 3 and 4. So this rather busy slide, I'm afraid, shows the population demographics. And all I want you to look at is in the red boxes. These are the lung cancer cases. And the important point here is that these are highly representative of the average lung cancer patients that we see. Median age around 72, sort of 60-40 gender split. The majority of patients have been smokers, so about 90% have been smokers, and more ex-smokers than current smokers. And again, about 44 pack years of smoking, and about half of them had a history of COPD. In green, I've highlighted the controls, which, as you'll see, are a few years younger on average, and they tend to have a lower smoking history rate, and you tend to have more never smokers. But again, representative of the patients presenting with suspicion of lung cancer, who luckily turn out not to have lung cancer. I should also say in these tables, we've split down between the 2 methods, M1 and M2. This table shows the histology of the cancer cases in each method. And as you can see, the majority, around about 50%, are adenocarcinomas, and around about 30% are squamous cell carcinomas. Again, a very typical split. We're now seeing more adenocarcinomas than squamous cell carcinomas due to changes in cigarette types and consumption patterns, and then a smattering of the other rarer types of non-small cell lung cancer. So before I take you into the more detailed results, we used smoking-related compounds in effect as a positive control to ensure that we were seeing a signal in the samples we were collecting. And this shows various smoking compounds that you'd expect to see, such as toluene and benzene, in the current smokers, but much lower levels in people who are ex-smokers or who have never smoked. So that's essentially just a positive control check. And these are the first set of results on the univariate analysis, again with the method 1 and method 2. And on the left-hand side, you can see 11 breath biomarkers, which differed significantly between cases and controls in either the early stage disease or advanced disease. And interestingly, you can see that in method 1, the less sensitive method, we are essentially picking up VOCs in more advanced disease, but the more sensitive method 2 began to pick up VOCs in early stage disease. So these were the 11 biomarkers with significant difference, but when we corrected for gender, age, BMI, and smoking status, this significance at the 5% level disappeared, and there were no significantly different features between the cases and the controls. We found that individual compounds differed in their discriminative potential, and this is allyl methyl sulfide. We found that of the reported features in the literature, we were only able to reproduce the results in 3. And the other interesting thing was that with some compounds, such as allyl methyl sulfide, we noticed lower levels in more advanced disease. Now, this is a metabolite of garlic, which has been shown to, garlic is known to have potentially be oncoprotective. And it is only an observation, but it's interesting that we're seeing lower levels in patients with more advanced disease than early stage disease across both methods as it happens. Is an observation which we may look into in more detail in the future. But then moving to the multivariate analysis, so again, 6 panels to look at here. But if you look at the 2 right-hand panels for the M1 and M2 methods, first of all, the blue line is the VOCs on the ROC curve. And you can see that it is only slightly above the sort of random, the dotted line diagonally across a ROC curve is essentially chance. And if you look at the orange line, which is the VOCs and the epidemiological risk score, it's slightly better, but actually doesn't beat the epidemiological risk score on its own. And if you look at the advanced in the middle and the early on the left-hand side, again, it's similar. So unfortunately, on a multivariate analysis, the combined breath biomarker, or either alone or combined with the LLP2 model, is modest at best. And the overall performance is not sufficient for the development of a diagnostic test. And we feel that there's probably many reasons that we can discuss about this, but it's likely that actually we're unable with the current methodology to see a difference due to sort of the analytic and biological variabilities between cases and controls. So what has this taught us? It's our conclusions, as I said, that while there are breath biomarkers that differ between subjects with and without lung cancer, their diagnostic performance doesn't exceed that of the risk model and doesn't meet the requirements to develop a clinically useful test in this population. But we've learned a lot about the workflows and how to go about this work, and we believe that our approach and methodology has been very rigorous, and possibly explains why in the literature to date there's been such a variation in the biomarker field in lung cancer, and that people haven't, to date managed to come up with a validated biomarker. But it's also taught us that probably we need to transition from open discovery to a hypothesis-driven approach. And what I want to do now is just show you on a few slides the work that we're now doing around the evolution program. And this is taking advantage of using an exogenous VOC probe, which Billy mentioned at the end of the last presentation. And the advantage of this is we hope to magnify the signal to noise ratio beyond, as I said, analytic and biological variation. And in this first program of work, we're using a probe called D5-ethyl beta glucuronide. And essentially, the first part of the evolution program is a proof of mechanism study. And I'll explain how this works. So essentially, D5-ethyl glucuronide is a hydrophobic compound. And when injected into patients, goes into the extracellular space. Now, within normal cells, there is a beta-glucuronidase. But because the glucuronide is hydrophobic, it can't penetrate the cells, and you don't get any cleavage of the D5-ethanol, which is represented by the orange dots, from the glucuronide backbone. So you don't get a signal. But in cancer cells, which are leaky and permeable, and the glucuronidase is excreted into the extracellular space, that can then cleave the D5 labeled ethanol from the glucuronide, which can then be breathed out and measured on GCMS. So that's the theory behind the probe. And we've done some in vitro and in vivo work. This is some in vitro data looking at a tissue microarray of 140 human lung cancer resection specimens, and essentially looking at beta-glucuronidase expression across stage 1, 2, and 3, as you can see on the left-hand side there. So there's high expression in the tumor microenvironment of glucuronidase, but it's not seen in the adjacent tissues in the lung away from the tumor or in healthy lung. And again, on the right-hand side, you can see this occurs in all three main types of non-small cell lung cancer. This is some in vivo mouse work where essentially mice bearing lung cancer were repeatedly dosed with the glucuronide probe. And you've got healthy mice in gray and tumor-bearing mice in blue. And as the tumor grows in size with time along the x-axis, you can see an increasing level of the D5-ethanol in the breath over time. And there's a correlation between the tumor volume and ethanol production. So this initial work has led us on to early human studies. And essentially, these are safety studies. These are phase 1A and 1B, and now phase 2 studies. And essentially, these are safety studies and proof of principle and dose ranging studies, where essentially we want to show that it's safe to administer this probe, which, as I said, is currently intravenous, but maybe in the future an inhaled probe. And we're trying to find the right dose to use. We want to be in the target zone on the left-hand side, where we find true positives in lung cancers and true negatives in healthy patients who don't have lung cancer, avoiding false negatives and false positives. So in the phase 1A, 21 healthy volunteers were dosed. And then we've recently finished, I say very recently finished, only in the last couple of weeks, a phase 1B study in Cambridge and Manchester, where we dosed healthy volunteers and patients with known lung cancer. And the phase 2 study is just opening as we speak. And this is going to confirm the robustness of the test and the phase 1 data, and also look at the performance in target groups. Because as I said to you earlier, patients with lung cancer come with lots of other comorbidities such as COPD, pulmonary fibrosis, infection, and so on. And we want to see if we can demonstrate the specificity of the probe and the production of glucuronidase in lung cancer. So to date, in the phase 1A and 1B studies, we've had no serious adverse events at all. It's very well tolerated, with only very mild side effects in a handful of patients, such as minor headache or nausea, the kind of things you'd expect in any phase 1A and phase 1B study. So more of evolution to tell you about, I hope, in the future. But I'd just like to move to my last slide now and summarize that initially in the LuCID study, an open discovery approach to lung cancer breath biomarkers has not revealed any biomarkers that we feel can be used to discriminate lung cancer from benign disease, following all the appropriate corrections and analyses. But moving forward, a more hypothesis-driven EVOC probe approach exploiting metabolic pathways, we believe is probably the way forward. And this shows early promise in some of our early studies. And as I said, safety and proof of principle have been met. And the phase 2 evolution study is just getting going. So with that, I'll end. Thank you very much for the opportunity to tell you about our work in the LuCID and Evolution Studies.
Brilliant. Thank you so much for that, Robert. Yes, it's been fantastic working with you over the years. And as we found, early detection of lung cancer is a pretty hard problem to crack, but one I think that we want to keep working on to make sure that we actually get there. Mark van der Schie is going to join as well for the Q&A. So again, just a quick reminder for everyone, post your questions in the Q&A at the bottom, not the chat function. So I'll kick us off. There's a couple of questions here. So it's clear, if you think about the endogenous or discovery-based approach, that from the study it doesn't look like that will have utility as a diagnostic. Do you think there's scope in future to think about identifying populations who are at risk to then go for subsequent testing, or is that something that you don't think kind of endogenous compounds would have potential utility for either?
I think so. Clinically, in a way, if you, for instance, the CT scan I showed you with the large mass in the lung, I don't necessarily need a test which is going to tell me that something the size of my fist is a lung cancer. It is highly likely to be based on the scan. I may need to get a biopsy to look at the histology. The biggest challenge is going to be the small nodules, the small cancers in a high-risk population. And at the moment, the screening populations are based on essentially people of a certain age who are ever smokers. About 15% of people that we see with lung cancer now are never smokers, and screening programs will miss these people. So actually, if we did have any adjunct, whether breath or blood-based, and there, as you know, there is work on a number of blood-based biomarkers ongoing that can help to enrich within populations who to look at in more detail, that is, would be extremely useful and powerful. And I think that is the direction of travel everyone's moving in the early detection. We need to first look at it in the people at highest risk, and then, or in parallel, in fact, move into people at lower risk. But of course, it becomes harder and harder, and you have to have more and more sensitive approaches to do that.
That's great. Next question may be more targeted towards Mark. So obviously, if you look in the breath literature, I've seen enough papers where you have AUC of about 0.95 for lung cancer detection. This isn't obviously what's being reported here. Do you think that means going forward, obviously we're focused on a probe-based approach, but the field as a whole should move more towards a probe-based approach, or should there still be attempts to do more global type analysis, looking at endogenous type compounds? And if so, why would you do that? Would there be a improvement in analytical approach or something like that that would warrant that, or should it just be go hell for leather on your probe-based approach? Mark, maybe you could take that one.
Yeah, sure. Perhaps a slightly political answer, but I think there's an argument for both. I would say when we started the LuCID study and during the running of this study, the way this was approached is really setting a new standard in terms of how you look at breath-based discovery. It also has taught us quite a few lessons around the risk of finding false positives, which for me has made me skeptical about these papers that you've described, where you see high AUC values, but you don't see structural elucidation. You don't see the appropriate controls in place for the GC mass spec, because we have had even occasions where looking at the chemical structure of a compound revealed it happened to be a cleaning agent associated with a clinic for lung cancer patients. So it's easy to be fooled by the data. So I think that's sort of a cautionary tale. And I would say, if you get to the point where the technology improves significantly, and I think this field is developing rapidly, the Orbitrap, for instance, is a fantastic innovation where I think there could be an argument there to look at biomarkers of interest. But I think this does warrant us to be quite critical of such data. But in many ways, I feel like this study is showing, even if you run a discovery study and you find associations, and maybe this is not the home run you're hoping for, that it differentiates between cases and controls, but it does show you where to look, what pathways are different. It has given me a lot more confidence that there is a meaningful signal. If you have 4 cohorts, 2 training, 2 validation, 2 different methods, where you do reproduce some of the same compounds, that gives me a high degree of confidence that exploring such pathways in a targeted manner, such as EVOX, could make a lot of sense. So from that perspective, I think a clinical test is more likely to be EVOC based, but there's tremendous value in doing discovery.
Yeah, that makes sense. Next question, Robert, you touched on a little bit. So obviously, we just need to have a test that can pick up early stage cancers. There's imaging currently, obviously the work that we're doing in breath. You touched on some of the work that's happening in liquid biopsy. I'm wondering if you could comment on what data exists in the liquid biopsy fields in terms of sensitivity at early stage disease. Well, what does the state of the art look like there?
Yes, that's a really good question. So there are many areas around circulating tumor DNA, circulating cells, exosomes work, a number of different areas in blood biomarkers. But for instance, probably the area which is getting most airtime at the moment is around circulating tumor DNA. And the work that has been done on that demonstrates that in advanced disease, you can detect ctDNA in patients with pretty high sensitivities of the order of 80 or 90% for advanced disease, but that falls off as you come down earlier stage. So work published by Grail and Annals of Oncology a year ago showed that when you came down to stage 1 disease, it was down to about 25 something like 20-25%, something like that. Now that's using panels, probing the blood. If you have a tumor-informed approach where you actually have the tumor and you can develop your panel from the tumor, in fact, looking at for people with minimal residual disease, you can improve on that. And recent work, in fact, presented at ESMO just the other day showed that in stage 1 disease, you can get up to a sensitivity of about 50%. But that's the difference between tumor-informed panels and non-tumor informed panels. And of course, if you're in a screening setting, you don't have a tumor to develop your panel from. So I think in all these different biomarkers, everyone's finding the same thing, that with early stage, which is where we want to be, it is much more challenging. The other possibility is that actually, of course, everyone plows the furrow they're most interested in, whether that's a breath group looking at breath, or a ctDNA group looking at ctDNA, or exosomes, or whatever. But it may be in the future we use a sort of multiplexed approach, where you use more than one approach, and you combine data. And of course, no one's really doing that at the moment, or they're only just beginning to think about that, because you've got to have interest in more than one area. But that's certainly an area that I'm interested in. There are others more on the clinical side saying, actually, okay, we can talk with all these research groups doing their own thing, but actually, what if you could, do a finger prick blood sample and a breath sample at home, and they get sent off, or a urine sample as well, and they get sent off together, and the data gets integrated. So will that be the way that will improve sensitivity with time? We'll see.
Fantastic. The next question, saying, since the glucuronidase is found in the tumor microenvironment, could you also track its progress in the TME using interstitial fluids or lavage? Maybe one for you, Robert.
Potentially, but that would involve doing invasive procedures on people to get that lavage of those samples.
Yeah.
So yeah, one could do it as a. I'm not sure how much that would add over what we've got at the moment on the TMA samples. But again, what I always try and think is, okay, you have an approach, you think of an approach, can we do this? But actually, is this going to be translatable to clinical practice? Is this going to be useful, to the individual at the end of the day?
Maybe potentially in indeterminate nodule management, where you have them in the clinic already as opposed to screening?
Potentially, yes. I mean, indeterminate nodules, we see huge numbers of, and the vast majority are benign. And we sometimes we follow them for up to 4 years to try and sort things out. But again, one wants approaches where we're not, hopefully doing too much to people. Doing CT scans, non-contrast CT scans on and off the table in 10 seconds, literally, is very easy to do. And people will tolerate blood tests or a breath test, but doing more invasive tests is more challenging. And also, I think it's a signal to noise ratio that these, if you've got a nodule which is 5 or 6 millimeters across, and it's got a volume of 80 cubic millimeters, in the volume of the entire lung, that is tiny.
And perhaps to add to that, mechanistically, what we'll be trying to do in the Evolution phase 2 study is in subjects that are undergoing surgery after the breath collection, is to obtain some tissue samples. It will be interesting to see sort of spatially if we can detect the presence of the probe within those tissue samples and correlate it directly to the breath signal. So we do believe that will give us quite a bit of mechanistic insight. But the probe itself, one of the attractive things from my perspective of an EVOC probe approach is that the probe has been designed that the cleavage molecules is extremely volatile. So it's actually more likely to end up in your breath than that you would be able to extract meaningful amounts in your BAL. So you would probably more likely find the uncleaved probe, which you put there in the first place. So I do think that spatial information is useful for research, but in the diagnostic setting, like Robert said, it's probably more challenging.
That's great. Next question relates to the probe administration. Is there a plan for the probe to be inhaled, and what advantage is there in that? Maybe Robert, maybe you could comment on the.
So at the moment, the probe is intravenous, and of course that, you know, has the challenges of persuading people to allow you to give an intravenous infusion, which is again terribly handy. So yes, going forward, an inhaled version would be a much easier approach. You know, people are used to inhalers for asthma and COPD and things like that. And again, I think that, you know, if we are going to use any of these technologies en masse, we need to be able to either develop them that they can be used at home or in maybe a GP surgery or a community hub, rather than having to come to a hospital and a research centre to have them done. So, you know, we've got to bear in mind, whatever we develop, we've got to then translate it for mass use, as it were, in order for it to be useful.
And the inhaled probe is actually in quite advanced stages of development. Do expect to start using that in the relatively near future. The reason to start with an intravenous one was more related to the pharmacokinetics, because it's easier to make sure that we are actually administering a controlled amount and that the delivery ends up in the tumor, so we can understand the mechanism. Where we do think, besides the patient benefit, there's also going to be benefit from sort of more direct targeting of the lung tumor when you inhale the probe. So that's very much an area of investigation.
That's great. And the probe, Robert, that you outlined here is targeting the extracellular glucuronidase. So the use of exogenous probes has obviously been deployed in imaging before, so things like a PET scan. I wonder if you could comment on other potential targeting mechanisms or probe type ideas where you're going to get some degree of selectivity towards the probe. Maybe Mark, you have maybe your best to answer that one.
Sorry, you broke up for 1 second. Could you repeat the last sentence?
So what are the other potential mechanisms that could be targeted within a VOC probe that could be deployed for early detection?
I think the interesting thing, I see the EVOC probe approach almost as a scaffold where you can change both the cleavage site and the reporting molecule. So there's definitely scenarios where you can think of combining multiple different targets. And there are several ones that are of interest at this point in time where you could actually start to think about targeting specific molecules that are, for instance, of interest for specific therapeutic strategies, and also build sort of multi-layered models that potentially could further increase your specificity.
So multi-stage targeting.
Yes, so I think so you could do multiple probes, but you could also create one probe that has a multi-stage cleavage required, where you could, for instance, see. So one of the things we're investigating is does glucuronidase that is extracellular, for instance, occur in heightened stages of inflammation, because it also is in macrophages. You can imagine if you combine, for instance, a macrophage-specific EVOC probe, it will allow you to see, hey, I see that this signal is predominantly coming from immune cells versus, hey, this seems to be coming from a cancer cell. So there's a lot of ability there to, even if you end up with false positives or false negatives, take a very targeted approach. And again, I think that's why the tissue biopsies could be very informative to help us understand how does the tumor biology relate to the results that we find.
Brilliant. We have time for a couple more questions. There's a question here. I think we touched on it a little bit earlier. So again, it goes back to discovery type workflows. And what is the major limitation for discovery studies? Is it around finding the chemical entity that differentiates the controls from the subjects, analytical sensitivity? And I suppose the bit I may add on that is, or are they just never going to be specific enough? Which I think is probably where I think, if you think about the biological mechanism that leads to the production of some of these things, is it just the nature of the biomarker or the analytical approach? Don't know who wants to start off first on that one.
I can. Yeah, I think you're right. I think there are two points. There's the sensitivity issue. You know, does this work on something the size of your fist versus something the size of your little fingernail? Okay, but patients with lung cancer who have smoked for many years, often the majority of 85% have, who are, as I said, median age of about 70, 72, have accumulate many other conditions: COPD, heart disease, vascular disease, pulmonary fibrosis, inflammatory lesions in their lungs, and therefore the specificity issue comes in. And it's not uncommon for, and surprisingly, I can't give you a figure on it, but it seems to happen in every MDT I sit in, that we have referred someone with lung cancer and we do a PET CT on them and find they've also got a bowel cancer or a renal cancer or some other cancer. So there are many other comorbidities these individuals have, maybe far more than, you know, patients with other types of cancer, such as breast cancer, who may be considerably younger. And we need the specificity, and the phase 2, where we're looking at contrast groups as well as patients with lung cancer. So we are specifically going to in the contrast cohorts, rather than we're not calling them controls, we're calling them contrast cohorts, will be people with COPD, with pulmonary fibrosis, with inflammatory conditions, in order to get some feel for that specificity. Because again, you know, the danger is we've got to try and minimize our false positives, because otherwise you go off down rabbit holes, putting patients through tests unnecessarily and inappropriately, which happens with every test we have. You know, there is no test that I can think of that has an L-shaped rock curve, you know, with, you know, the apex in the top left-hand corner. And of course, it's the false negatives and false positives that always make the headlines and people's, you know, tests, rather than the sensitivity and specificity.
Brilliant, thanks, Mark. Anything to add on that?
No, I fully agree. I think we touched briefly on the analytical side of things here. I think with metabolomics being the end product of the VOCs being metabolites, the end products of your body's metabolism, there's going to be a lot of commonality, sort of these being end products of a wide range of pathways. So again, this points you into the direction of the relevant pathways, and with an EVOC approach, you can target more upstream, and that's essentially what we're doing, where the pathways are more specific, and you can actually design a molecule in such a way that it achieves a specificity akin to, for instance, what a biologic drug or an antibody drug combination would get you. And that would never happen in pure discovery.
Great. There's one last question here. Could you describe the LuCID controls in a bit more detail? So they weren't healthy subjects. So these were people under clinical suspicion of lung cancer. I think that's
they were, and that's a really important point, because often with biomarker studies, people compare cases with healthy volunteer controls. People who are 30 years younger, with no comorbidities at all. But in fact, if you're going to, before you do anything else, you want to start with controls which are as similar as possible in age and comorbidity background as your cases, except they just don't have lung cancer. So it is not uncommon for, I can have two people. They've both been unwell for a few weeks. They've both had a nasty cough. They've both been losing some weight. They've both been, coughing up muck, and they had coughed up a bit of blood. And I put them both in the CT scanner, and they've both got shadows in the top of their right lung. One has lung cancer when biopsied. The second one has pneumonia when biopsied, with no evidence of lung cancer. You give antibiotics to the pneumonia, and over the next few weeks, the mass completely disappears. But on day one, the two cases looked, like peas in a pod, as it were. So, and this is, you may think, well, can't you tell the difference, between lung cancer and pneumonia and things like that on a CT? And the answer is no, you can't. Often they can look remarkably similar, and the symptoms, there are no specific symptoms for lung cancer. They're very generic. The symptoms, when people are symptomatic, they're very generic symptoms. And this is one of the many challenges in lung cancer.
That's great. That's very helpful, because I think it interests and feeds into the broader debate of, again, some of the foundational elements in breath haven't been super well established. What's on breath? What are the ranges? What do they like in healthy controls? And then broaden that out into different disease cohorts as well. I think Mike this morning touched on the importance of getting the appropriate controls for the clinical question that you're actually trying to answer.
When we publish, so we're writing up LuCID at the moment. When we publish, we will have a table in it of the final diagnoses of the control group. Or grouped at least into different areas. But I can tell you that it will be areas like infection, inflammatory conditions, some benign tumors, organizing pneumonia, one or two people with masses in their lungs which turned out to be sarcoidosis, a variety of things like that.
Excellent. Well, we've got to wrap it up there. Thank you so much, Robert, for the talk and the collaboration over the years. It's been wonderful working with you. And again, I think exciting times ahead with the Evoke Probe approach and Evolution 2. And thanks, Mark, as well, for dialing in to help with the questions.